Today we are going to talk about the bioavailability and the bioequivalence. So bioavailability is a fraction of unchanged drugs reaching the systemic circulation following administration, so by any route. So this one, let's recall our second lecture. So over here, so if we, for example, if we take an oral drug, which start with like a 10 milligram dose, of course it can be 10 units or 10 the other units, doesn't really matter, right? Let's assume we have 10 milligram at the very beginning. So in the GI tract, it can be absorbed into liver through the portal vein. And during this process, maybe two of them cannot be absorbed due to whatever reasons. For example, for the solubility, permeability, stability issue. So that's only eight can finally get absorbed, right? Over here, 1, 2, 3, 4, 5, 6, 7, 8, right? So two lost. Now they can enter the liver. So in the liver, we know the liver is a major organ for metabolism. Maybe two of them get metabolized, right? So if they are, if the drug is a substrate of certain enzyme, so not all of them, of course, can be metabolized, but of course, not all of them can be survived, right? So in this case, another two, maybe for example, get metabolized. Now the finally we only have six survive from the liver metabolism and also and go across the intestine barriers. Finally, they can reach the body circulation. So six. So now let's see what is the fraction, right? So we start with 10, right? Only six can finally reach the body circulation. So that means we only have 60%, or we can say 0.6, right? Reach the body circulation. So the bioavailability for this one is 60%, or we can say 0.6, right? So that's what is a bioavailability. So by definition, so a drug that is administered by intravenous, so has a bioavailability 100%. So by IV. In this case, let's see this one. If we start with 10 milligram, for example, if we give this drug by IV injection, so all of them can enter the blood circulation, right? Or we can say the bloodstream or like the body circulation. So over here, all of them get into the blood vessel. So that means for the IV, we have 10 out of 10, all of them can reach the body circulation. So which is one, right? Or we can say it's 100%, right? So these two are the same, right? Okay. So IV, 100%. And for this one, bioavailability provides a estimate of the fraction of drug absorbed from the formulation, right? That's true, right? So for this one, if it's 60%, that means 6 out of the 10, or like the 60% of the original dose can finally reach the body circulation. So that is how the bioavailability estimate the fraction. So the next one is bioavailability can be used to predict the clinical efficacy. So if the concentration is correlated well with the effect, right? So of course, if you have a higher bioavailability, that means more drug get absorbed into the body circulation, right? So if the more drug get absorbed, that means you will have a higher concentration, right? Higher concentration usually is correlated to the higher or the more will relate to higher effect, right? So this table shows some like the general, some like I give you some idea about like bioavailability of different route of drug administration. So for example, IV, remember this, 100%. For all the other routes, so in general, they have like a more or less, right? So for example, intramuscular is still pretty good, right? More than 70%, and some of them can reach 100%. But for for example, for oral, it can be very different, right? So some drug has a very poor bioavailability. That means only 5% can be absorbed. So that means if you give 100 milligram of dose, so probably only 5 milligram is useful, right? So the remaining 95 just get lost, right? So, but of course, some drugs, their bioavailability can be like close to 100%, right? Like similar to the inhalation and radical. So just more or less, but still, in general, the bioavailability should be smaller than 100%. So that will be give you some idea about the bioavailability of a different route. So the factors that affect the bioavailability, so including the first pass extraction, or you can say the first pass hepatic metabolism. So this one, the first pass, of course, that's relate to any factor. But in general, if we didn't specify whether it's liver or the other side, so usually when we talk about the first pass, when we talk about this one, we refer to the hepatic. So that means liver. Okay. So let's see it from over here. So in this case, if we give a drug orally, so it will dissolve in the GI tract, right? And some of them can get absorbed, right? So and through the portal they can enter the liver. So liver is a major organ for metabolism. So they have abundant enzyme over there. So if the drug happens to be a substrate of the enzyme, it can may or may not get metabolized, right? So some of them, of course, maybe get metabolized, right? And because this is the very first time for the drug to meet with the enzyme. So this is why we call it first pass, right? Because it's the first time pass through the liver. So we call it first pass extraction. So the one that can survive the liver metabolism can reach the body circulation, okay? So the first pass extraction, of course, can can affect the bioavailability. So the next one is solubility. So for any drug, in order to be absorbed, usually it has to be dissolved first. Okay. So if the drug is not soluble, that means they will precipitate out in the GI tract. If it's not soluble, that means they will stay in a really big particle which cannot penetrate the intestine membrane, right? So the absorption will affect the bioavailability because the dissolution, of course, is the first step for the drug absorption, right? So over here, and permeability, same thing. If a drug has a very good solubility, probably their permeability is not good, right? So if they are not penetrate this one, if they don't have a good permeability, that means they are not able to pass through the intestinal membrane. So they will stay over here, then get blocked by the intestine barrier. So that means they are not able to be absorbed. So permeability, stability, easy, right? If they are not stable, then of course, if in the GI tract they degraded or metabolized or hydrolyzed, that means they just disappear in the GI tract, right? And then maybe the formulation issue. So some formulation they have a certain limit or they have a certain mechanism, so that can also affect their absorption as well. Okay, so this one. Here, I mean, for all of these factors, so probably the first pass extraction is most important one. So as I said, it's called a rapid metabolism of an oral drug uh, before the reaching the general circulation. So because this is the first time to pass through this one, so this is very important. And also remember this. So higher first pass extraction, that means more drug get metabolized, right? So higher first pass extraction will cause a decreased bioavailability. So in general, first pass extraction will decrease the bioavailability of oral drug. Okay, because for the other route of drug administration, so they may not pass through the liver. For example, intramuscular, right? Inject into like the tissue, like the muscle, so they can go through the here, right? Or sublingual, they can bypass the liver. So that means they don't really have a first pass. But oral, yes. So they have to go through the liver first. So this is very unique for oral drug. And the solubility, as I mentioned, so the drug molecule need to be dissolved for absorption, right? So this one, I mean, you can read this, so it's pretty straightforward. So permeability. So this is one thing. So in general, as we talked about during the class, right? So for the our body is kind of like hydrophobic, right? So in general, hydrophobic drugs are more permeable. Hydrophobic, that means lipophilic, right? So lipids and the water, right? Water will be hydrophilic, right? But over here, hydrophobic, they have a they are less soluble but more permeable. Because the solubility and the permeability, as we mentioned, usually they just opposite. So if a drug, any compounds, if they have a very good solubility, so their permeability can be a concern. So a good example is like the vancomycin. Vancomycin, the solubility definitely is really good, but if you want the systemic effect, you cannot give the oral vancol because oral vancol cannot be absorbed. Okay. And the salt form, so salt form, remember this, salt form is more hydrophilic because the reason is salt form is charged, right? It's more polar. So over here, I want you to just put these three together. Polar, salt form, and hydrophilic. So salt that means charged, right? Charged, polar, hydrophilic. So these are kind of similar property, okay? But if a drug is very water soluble, they have a less permeability. So the ionized drug, so that means they are less charged, right? So that means more polar, non-polar, right? So they have a better permeability. Okay. So this is why. So for most of drug can maybe affected by the GI tract pH, right? So here, I mean, this one you can read by yourself, but to make it easier, I want you to remember two statements over here. So in general, acids more permeable in acidic condition, bases more permeable in basic condition. So let's go back to the renal clearance, right? For renal clearance, remember this. For the reabsorption, right? We talk about the reabsorption, right? So absorption pretty much is just the similar property with permeability, right? If you are more permeable, that means reabsorption can be more, right? So for the renal clearance reabsorption part, we have to remember that acid is more permeable or more reabsorption in acidic condition, right? Bases more permeable or more absorption in basic condition. So that's is universal true, okay? So I want you to remember this, okay? So for example, for aspirin, which is acids, right? So and our like the stomach has a lower pH or the acidic pH. So that means for the aspirin, pretty much the aspirin can be absorbed in the stomach, right? But in the GI tract, because GI tract usually has a like a neutral pH around 6, 7. So that means it's more basic, right? More basic, right? So this is why for acidic drug, their absorption, in the stomach is pretty good, but in the intestine probably is not that good. So, I mean, these are all like the conversion from the ionized form to the ionized form. But in general, I think as long as you remember these two statements, you don't really need to worry too much about that one. Okay. So the stability. So the stability, of course, if the drug is not stable, that means they are not being absorbed, right? Because even before absorption, they get degraded already or destroyed already, right? So a good example is for the biologics. So what are the biologics? Biologics, just like proteins, right? Big molecules, right? So because they are proteins, so we in our GI tract we have a lot of the proteinase which can digest or hydrolyze the proteins, right? For example, for insulin. Insulin is like we can call it peptide or we can call it as a protein, right? Because it's kind of like a not too big in terms of the amino number of the amino acids. It's not that really not that big, but it still is you can consider it as a polypeptide, but you can also say it's a protein drug, right? So insulin, you have to, it has to be given by like the sub-Q, right? By injection, right? But if we oral insulin, it will get degraded in the GI tract because, it's just protein. Because our body need protein, but we cannot absorb the protein directly. So we have to digest the protein into amino acids, then which can be get absorbed. So that's a stability issue. And the formulation, of course, right? So the tablets, capsule, the coating, they all can affect the absorption. So the particle size, so in general, smaller size, they are more permeable because they're small, right? So if the particle size is too big, then definitely they have a hard time to be absorbed. So smaller the particle size, more absorption. Then more absorption, that means more bioavailability, right? Because more drug get absorbed, right? So the other one is about like the physiological or pathology issue. For example, the integrity of the GI tract. So sometimes, if you increase the gastric emptying in time, so absorption will be more because it give you more time to stay in the GI tract, right? So that means the more drug get absorbed, right? And also maybe the diarrhea can reduce the drug absorption. because they're real. That means you have a really have fast like the path through the intestine, right? So the drug doesn't have enough time to be absorbed, right? So this just the pathology or the physiology that can also affect the bioavailability. So far we talked about like the factors that can affect bioavailability. So of course for the PK, one very important part is how to calculate the bioavailability. So we went through this before, but still now we can do more practice because this is still the bioavailability calculation is a very common and a very important part of the PK as well. So for bioavailability, we first one we know we have a absolute bioavailability. So absolute bioavailability, that means remember this. So is you compare your drug, like your like formulation or your drug, and your certain like the route of administration compared to the IV. So whatever you have compared to the IV administration, because IV has 100% bioavailability, right? If you compare with IV, which will give you a we call the absolute bioavailability. So absolute bioavailability technically is the fraction that can really reach the body circulation. So in addition to the absolute bioavailability, we have the relative bioavailability. Relative bioavailability, it won't tell you like really what is the fraction that can reach the body circulation directly, but it will tell you like the compare the formulation A and with the formulation B. Okay, so relative bioavailability can be any number. So absolute bioavailability, as I said, IV injection has the highest bioavailability, which is 100%. So that means absolute bioavailability, remember this, can never over like the 100%. So absolute bioavailability will be smaller or at the most equal to 1 or 100%. So this one, keep in mind. It's a very important concept. So absolute bioavailability should be smaller or at the most equal to 1 or 100%. However, relative bioavailability really depends your A to B or B to A, okay? Okay. So for example, so the relative bioavailability A to B, maybe for example, maybe like the 50%, okay? So this is F A to B. So in this case, of course, you can also say, what is the bioavailability B to A, right? So B to A, that means reverse the 50%, right? 50% is 0.5, which is 1 second, right? So now the B to A would be reversed, right? Will be 2 to 1. Or we can say this 200%, right? So in this case, you will know for absolute bioavailability, at most 100%, cannot over 100%. That's it. Relative doesn't matter. It really depends which one goes first, right? A to B or B to A, right? So this is also very important. When you calculate relative bioavailability, make sure it's A to B or B to A because that will give you a reciprocal of the other number. So that's very important. Otherwise, you're not able to get a correct answer. Okay. So these equations are to calculate the absolute bioavailability. So basically, how to visualize this equation? Remember this. Actually, is their AUC ratio, right? But of course, you have to normalize to their dose, right? So when you compare this one, of course, apple to apple, orange to orange, right? So if you have a 10 milligram dose, 10 milligram produce certain AUC, then you have to compare with like a 10 milligram IV as well, right? So the oral, if you give more, of course, it will have a higher AUC, right? So you have to make sure they are on the same scale. So that means they have the same dose. So we have to divide by the corresponding dose, then over the other AUC. Then we can calculate the ratio, right? So the relative bioavailability is similar stuff. So A to B or B to A. If A to B, that means A on the top, B on the bottom. So if you B to A, then you just need to reverse it. So that's definitely that will give you the different number, right? So this is a calculation of the bioavailability. So next one, why the bioavailability or bioequivalence is important. So I like to talk about this one. So brand name drug and generic. Okay, brand name that means new drug, right? So usually in order to develop a brand name drug, that means it's totally new, right? So you have to submit a protocol called a new drug application, NDA. So remember this, NDA is for brand name drug. Okay. So if the brand name drug get expired, the patent get expired, or like a new drug protection get expired, that means you can develop your own, we call a generic version, right? So generic version, that means almost same drug, but because of the patent get expired, so that means you can also do this drug, right? You don't have really have to like synthesize a new compound. You can just buy the drug and you can do the formulation, then you can just market it, right? So in this case, of course, you don't have to do all this, all this experiments again, because a lot of them has been done already, right? You don't really need to repeat this, right? So now you can just submit, we call the abbreviate new drug application, so ANDA for FDA to get the approval for the generic version of the drug. So this table just shows the difference between the brand name and the generic. For example, for the patent, brand name, of course, they have the patent protection. So that means as long as they have a patent protection, you are not able to do it, okay? But for generic, there's no patent protection anymore. So you can you can just copy the drug from the other company and you can you can market it by yourself, okay? And the price is high, right? Because for brand name drug, they have to spend a lot of money on the new drug development, right? For the generic, of course, you can avoid all this like very cost, very pricey process, right? Because for the clinical, for example, clinical three can cost a lot of money, right? But you don't have to do that anymore. So you can just directly do the formulation and do some a little bit clinical study, then you can get marketed. So that means your invest is low. So this, of course, the price is low, right? And name for brand name drug, you can have a marketing name, so you don't have to label to use the chemical name. But generic, you have to use the chemical name because you don't have your own brand, right? Because their brand name is kind of like they get protected, right? So for example, for Tylenol, right? So Tylenol is the brand name, but actually if you have a generic version, you cannot use Tylenol, right? Tylenol, right? You have to use acetaminophen, right? So Tylenol only for the brand name, but of course this one is more expensive. But of course you can buy the acetaminophen. So they are same thing, but because they it is a generic version. So generic version, so that means they are cheaper. So now let's talk about how to develop a generic version and what is a kind of like a minimal requirement you have to approve. So these two is good as the brand name drug. So now we talk about like the bioequivalence. So the bioequivalence over here. So the safety and efficacy of a generic drug is established by showing we call the therapeutic equivalent. So therapeutic equivalent has two components, pharmaceutical equivalence and bioequivalence. Okay, so pharmaceutical equivalence, of course, is not my focus for the PK study. So basically, for this one, make sure they have the same active ingredient. So if you have Tylenol, that means you have to have the acetaminophen. If you have ibuprofen, that means you have to find the corresponding brand name drug. Okay. So you have to make sure the same active ingredient and the same strength, right? Like 50 to 50, 100 to 500, right? Dosage form like a capsule to capsule, tablet to tablet, and the oral, IV, right? So this one is we call the pharmaceutical equivalence. So for today's lecture, we will focus on this one. So bioequivalence. So bioequivalence rate and extent. So what does this mean? Okay. So over here, let's see. So next slide. So this one I just find from the website from the US FDA website. So the definition. So it's pretty long. Okay. You can read this. You can pause this and read this. And also I find a copy from the EMA, so European Union, right? So over here. So you can see it's pretty long, but you don't have to read through all of this. You just need to focus on this one. So these two, the rate and the extent, right? You can see rate and extent of absorption, right? Same thing, right? Rate of extent of the, the same thing, right? So the absence, right? The significant difference in the rate extent to which the active components can be absorbed, right? So remember like this. So basically, the bioequivalence is a rate of extent of drug absorption are similar. So then what is rate? What extent? So basically, rate means how fast, how fast. Extent, that means how much, right? So rate is just the velocity of this absorption, and extent is just the amount that get absorption. So that's is the rate and extent. So then how to evaluate, how to determine these two are like equivalent or similar? So I mean, there are several ways to determine or establish the bioequivalence. So for example, first one, this is most common. It's called a pharmacokinetic study. So this is the most common study to determine the BE. So in certain study, you have to use like a pharmacodynamic study because for certain drug, they don't really have like the measurable drug concentration, right? So in that case, especially for those like the topical use, right? If you measure the blood concentration, probably you are not able to detect anything. So then in that case, you are not able to apply the PK study, right? Because PK study technically is a study of the concentration versus time, right? Or we can say the blood concentration or plasma concentration, right? For those like a topical drug, we don't have measurable blood concentration. Now in that case, probably we can use a pharmacodynamic study, okay? And also similar to the clinical endpoint study. So these two technically are very similar, okay? Because they are all talk about the pharmacologic effect, right? And a certain drug, you can only use like I mean, you just need to do some like in vitro study. So as long as you show like their like the dissolution profiles are similar, then you can assume they can be bioequivalent. Because those drugs, if they really have a very good solubility and permeability, then you don't have to worry too much. So as long as your formulation, your dissolution, or the disintegration rate is similar, so pretty much you can have them have a same almost the same like the bioequivalence. So this is why for this one you can establish the bioequivalence. But still, among all of this, the most common, okay, most common is the pharmacokinetic study. So this is most common way to determine the bioequivalence. So as I said, for the bioequivalence, it's the extent and the rate. So for PK, of course, we can have like the curve, right? Plasma concentration curve, right? But of course, we cannot like say, okay, these two figures look similar, then they are bioequivalent. So we have to set a certain criteria, right? So then the next question is, which parameters are used to evaluate bioequivalence? So this slide is very important. This slide is very important. So AUC is to evaluate the extent of absorption. Basically, is how much drug can be absorbed, how much, okay? And the Tmax is a rate of absorption. So it's how fast, okay? How fast. And the Cmax, you can use it for both. So extent and the rate. So this slides, just remember this. I want you to remember this slides. So it's very important, okay? So extent and the rate. So in general, the depending on the drug, okay? So in general, the extent is more important than the rate. So extent, that means the overall drug exposure, right? So in general, for the FDA, they focus more FDA focuses more on the extent, like the AUC and the Cmax. So less focus on the Tmax because Tmax that's really somehow just determine the onset of action, right? Either faster or slower, but depending on the purpose of the drug. So sometimes you don't really need to worry too much about like the onset time, right? But of course, if you want to aim for like the fast, rapid, or the rapid onset of action, then definitely the Tmax is important. Otherwise, the Tmax, of course, is not so essential. So let's see how the AUC or the bioavailability can affect the drug concentration. Okay, so bioavailability can be used to evaluate the absorption extent, right? As we mentioned before, right? So larger F is associated with a larger AUC. So over here we say we never talk about like a biovariability over here because biovariability that means for you have to do like two different the formulation, right? So we mentioned about that one. We mentioned about the like relative bioavailability, right? So basically we compare the AUC of two different formulation. So their comparison of their AUC basically is about relative bioavailability, right? But in general, if you have a higher bioavailability, you have a higher Cmax and AUC, right? So you see over here. So if the bioavailability is 20%, so the purple line, but if you have a higher bioavailability, of course, the concentration will be increase, right? Will increase, right? So that's increase will give you a higher Cmax and a higher overall AUC, right? So the next one, the Ka, so absorption rate constant, right? So if you still remember for the oral drug, right? So if you have a larger Ka, so that means absorption is really fast. Just as I mentioned before, right? For example, if you're hungry much, then you eat a hamburger like in 1 second. That means you will feel full right away, right? So that means you have a smaller Tmax, right? Because that can resolve your issue of the starving, right? If you are really hungry, then for this one, if you eat very very fast, that means you have a very fast onset. So also fast onset, that means smaller Tmax, right? So larger Ka associated with smaller Tmax and higher Cmax. But remember this, Ka does not affect the amount of drug get absorbed. So that means the Ka has nothing to do with the extent of absorption. Because if you have three hamburger, regardless how fast you eat them, you can only have three, right? So you eat it slower, you still have like three hamburger, right? So that's something I want you to pay attention. So this slide is important. So this is a criteria. So when we compare like the Cmax and AUC and how, so what is a criteria? That means they are to determine, to establish whether they are bioequivalent or not, right? So of course, if we do the AUC, we cannot always get like they are identical, right? So probably their ratio is 95 or maybe 110, maybe 105. So we have to set a limit, right? So as long as the limit is inside the range, they are good, right? So if you learn about like statistics, you will know this 90% confidence interval, right? So basically the confidence interval, that means the true ratio is, right? So the 90% of the chance you can get the true ratio of the AUC, right? So so for the 90% confidence interval should be inside the range of 80 to 125%. So for example, for a drug A and B, their ratio, okay? So AUC ratio maybe it's like 105%, and the confidence interval maybe it's 95 to 1, maybe 111, okay? So in this case, you see 95 to 111, so they are inside the range, right? So that means they are bioequivalent. So the confidence interval of this one means you have 90% of chance your true ratio is inside this range. So if we do a study, we determine the ratio is 105%. But I mean, this is only one study. Does not necessarily mean next time you do it, you can always get 105. Maybe next time you got like a 100%, and then maybe the next time is maybe 110, 110, okay? So if you do a different study, so the first time you got this, second one you get this, and the third time you got this. But whatsoever 90% confidence interval, that means you have a 90% of chance the true ratio is inside the 95 and the 111. So all you can simply think like this way. If you do 100 times, okay, 90% of the times you can get this one. Maybe the 10 times, maybe you can get like the ratio is 94 or 92, okay? But this chance is just very small. But the key is remember this. So the 90% confidence interval should be inside the 80 to 125% range. So the next one is no significant differences in Tmax. So this one, as I said, is not so essential. So it really depends on the drug. If there's no difference in the Tmax, it's good. But if yes, you just need to justify whether the Tmax is essential or not, whether the whether the onset time is essential or not. If not, then probably you don't have to worry too much. Okay. But still, I put over here because that's just, by from the FDA guideline. But this one, of course, that's has some space you can discuss. Okay. And this one, for a drug with a narrow therapeutic range, so acceptance interval may be tightened, right? So we have 80 to 125 for narrow therapeutic range. So that means, for example, for the one I just mentioned, so for example, maybe like the 85 to, if you 90% CI, 85 to maybe 120, okay, for example. For regular drug is fine, but for the narrow therapeutic range, so if you want to aim for, I only allow 10% difference. Then in this case, I mean, if the ratio is 88, right? That's still fine, right? For a regular drug. But for narrow therapeutic window drug, so this is greater than 10% already, right? It's 12% already. So this is why instead of we use 80 to 125, you have to use either 90 to 111. So that means will be narrower, right? But for the highly variable drugs, so acceptance interval, you can maybe extend a little bit. Because this one is just because they are highly variable. So maybe this time it's like 100%. So the same drug, the test next time maybe 120%, right? So in that case, we don't want to panic, I mean, just to get a punish to the company, right? Because that's not their fault. It's because of the drug itself, right? So in that case, the Cmax can be extended to like maybe 75 to 133 or 70 to 143. So that means as long as you prove that it is a highly variable drug, you can extend this to get like easier to be approved. So this criteria I want you to pay attention. So that's important. So the next one is about the study design. So study design for this one. So usually we use we call the two-way crossover. Why we call it as two-way crossover? So we have two groups, right? So group one, we have like the subjects, usually it's 18 to 24 subjects. We separate them into like group one and group two. So group one takes the test formulation and the group two reference, right? So usually this is a brand name drug, right? This is your drug, right? So after this, after taking the first dose, we have a washout period, right? So period, right? So but for this one, usually it's over 5 t-half, right? So why 5 t-half? So we talked about this, right? Because after 5 half-lives, that means the drug get eliminated, almost entire drug get eliminated, right? That means no drug remaining in your body, right? So after 5 half-lives, I mean, to be more practical, usually we set like 1 week, right? Because most of the drug, their half-life is less than 1 day, right? So usually 1 week, that means sufficient, right? And also 1 week is easier to handle, right? If you do the study like the healthy subject, maybe if you start to do it on Saturday, that means next Saturday, right? So they don't have to like if they have work, then they are not able to come, right? So usually it's 1 week. Then after 1 week, if for the group one, if they take the test drug, they will switch to crossover to test to take the reference drug. For those take the reference drug, they will take test drug, right? So why we call crossover? So you see, do you see a crossover here? So the crossover. So the good thing about crossover, basically you everyone compare with themselves, right? You take the test, you compare with their reference, right? You take the reference, you compare with your own test, right? So that will reduce like we call the inter-subject variability, right? And the parallel study. So that's easy, right? Just group one, group two, one take a test, one take a reference. Then one time you are fine, right? For the crossover, definitely take a longer time. But for this one, I mean, usually it's 1 day or 2 day at the most, right? But for this one, you take like at least 2 week, 1 week, actually 2 weeks, right? So So if you have more product to test, then you can use a Louding Square. For this one, probably it's a little bit too complex, so I don't really require you to know. But what you have to know is about like these two. Okay. So usually the fasting and the fat, usually both fasting and fat has been tested if the drug get kind of affected by food. Otherwise, if the food has nothing to do, had a very little impact on the absorption, then probably you only need to do fasting stage. That will be good enough. So compare with the parallel study, crossover has definitely usually it's better, it's preferred, okay? Because it compare with themselves, right? So your own test compare with your own reference, right? So this we call you only need to consider the intra-subject variability. So that means it is an intra-subject comparison, right? So you compare with yourself, right? Therefore, they have a lower variability. Lower variability, that means it should have a narrower 90% confidence interval, right? So also because technically you double the sample size, right? Because you take two, right? Two doses, right? So you only need a fewer subjects. So for example, if you have like 24 subjects for the crossover, if you want to do the similar stuff, use the parallel, that means you have to double the subjects, right? So because for this one, 12, 12, that means total 24. But for this one, you have 24, 24. That means 40, at least 48, right? So parallel usually you have to double more than or probably more than double of the number of subjects. But sometimes we have to use parallel. So if a drug with a very long half-lives, so why? We have a washout, right? If the washout is 1 day, fine, right? You just need to wait for 5 days or like 1 week, right? How about like if the half-life is 20 days, okay, for example, if the half-life T half is 20 day, okay, it's 20 day, okay? That means washout period is at least 100 days, right? That's 3 months, right? So it's just not very practical to do that, right? Because it's day one, you start to do the study, and after 3 months, you ask them to come back, and probably you will have a lot of subject drop from your study, right? So this is not very practical. And a certain time, maybe the crossover design is not practical. For example, for a certain drug, maybe they are toxic, right? You don't want them to take twice, right? So you want to minimize the potential impact on their health, right? So probably you just need to do this one time, right? Because that's, you don't want them to get exposed to the risk twice, right? So that's about like a parallel. But this slide is important as well. So these are the summary. This is a summary of the whole lecture. So I want you to read through this and also get prepared. And also I will have another video talk about like the class activity.